Hi, everyone. Welcome back to the 2025-2026 Oncology Residency Clinical Pearl Series. Today, I'll be presenting on the ATOMIC trial, which evaluates the use of atezolizumab with FOLFOX for adjuvant therapy in patients with stage 3 mismatch repair-deficient colon cancer. For the objective of this presentation, I will first go over the background of the ATOMIC trial, describe study parameters, strengths and limitations, and results, then go into more detail about implications of the results of this study. Colon cancer is the fourth most common cancer in the United States and was projected to cause the second most deaths in 2025 based on Sears database statistics. When it comes to deficient mismatch repair or microsatellite high colon cancer, it makes up around 10 to 15% of these cases. Previous studies have also shown that deficient mismatch repair colon cancer has intrinsic resistance to fluoropyrimidine therapy, but that if oxaliplatin is added on, it can have some utility, which is why FOLFOX has become the backbone of colon cancer treatment. When it comes to treating patients with metastatic deficient mismatch repair or POL-D1 mutated colon cancer with ultra hypermutated phenotype, the NCCN guidelines recommends the use of checkpoint inhibitor immunotherapy for initial treatment. This is based on the Keynote 177 trial that examined the utility of pembrolizumab to fluoropyrimidine-based chemotherapy. What they end up finding was that in patients with metastatic deficient mismatch repair colon cancer, they did have a higher median progression-free survival with pembrolizumab of 16.5 months compared to 8.2 months in the fluoropyrimidine-based chemotherapy group. And this was also statistically significant. However, if a patient did receive prior immunotherapy, then it is recommended to treat the patient with nivolumab and ipilimumab. This is based on the Checkmate 8 HW trial that found a higher progression-free survival in patients that received dual immunotherapy compared to chemotherapy. Now, what is interesting is that the NCCN guidelines does recommend all FDA-approved checkpoint inhibitors for patients with metastatic disease. There are not individual clinical trials that examined all these other immune checkpoint inhibitors besides pembrolizumab, nivolumab, and ipilimumab. But the concept of why all these other immune checkpoint inhibitors would be useful in treating this patient population makes sense because with deficient mismatch repair, there is a higher likelihood of the cancer mutating. So by preventing the cancer cells from inhibiting the activity of T cells, it can allow the immune system to be able to track down and destroy cancer cells regardless of the changes in surface antigens that these newer cells may exhibit. Based on the fact that patients with deficient mismatch repair colon cancer have a higher likelihood of cancer cells mutating, it does make sense that the investigators of the ATOMIC trial would analyze if there can be better efficacy outcomes with the addition of atezolizumab to FOLFOX compared to FOLFOX alone, especially now that the NCCN guidelines does recommend any FDA-approved checkpoint inhibitor for the treatment of metastatic deficient mismatch repair colon cancer. The ATOMIC trial is a phase 3 international randomized trial that conducted its study primarily in the United States and Germany. It was funded by the National Cancer Institute of the National Institutes of Health and Genentech, which is also the manufacturer of atezolizumab. They looked to enroll patients who were 12 years of age or older with complete resected deficient mismatch repair, stage 3 colon adenocarcinoma with good performance status. They also did include patients with Lynch syndrome, which makes sense since this is a genetic colon cancer predisposition that accounts for 2 to 4% of all colon cancer cases. This results from germline mutations in DNA mismatch repair genes like MLH1, MSH2, MSH6, and PMS2. They excluded patients who had any previous chemotherapy or radiation, but they did allow patients who had one cycle of FOLFOX before enrollment to allow sufficient time to obtain MMR test results. For efficacy outcomes, the Atomic trial investigators evaluated the disease-free survival, overall survival, and safety. For statistical methods, they used standard statistical methods and analyzed an intention to treat population. They calculated that the randomization of 700 patients with 165 events of disease recurrence or death would provide a trial of 90% power to detect a hazard ratio of 0.6 to favor the atezolizumab group. For overall survival, the investigators calculated that approximately 163 deaths would provide a trial of 90% power to detect a hazard ratio of 0.6 to also favor the atezolizumab group. When it came to baseline characteristics, they were similar between both groups. They did have a relatively even distribution of patients with high-risk disease and low-risk disease. High-risk disease in the trial was defined as a tumor stage of T4, node stage of N2 or both, while low-risk disease was defined as a tumor stage of TX, which is unknown depth of primary tumor invasion to T3, and a node stage of N1 or N1C. They also did have a low median CEA after surgery in both groups. And while CEA is not necessarily a reliable indicator of cancer diagnosis, it is notable that patients in both groups likely had relatively lower disease burden after surgery based on this metric. Now, when it came to the results of the Atomic trial, the atezolizumab group had a higher 3-year disease-free survival and 5-year overall survival percentage than the FOLFOX group. But the overall survival was not statistically significant, while the 3-year survival was. The silver lining from this is that if a patient cannot get started on atezolizumab right away due to insurance coverage or other logistical reasons, it likely would not impact the care of the patients. For safety results, all patients in the atezolizumab group experienced adverse events of any grade, while for the FOLFOX group, majority of patients also did experience adverse events of any grade. However, patients in the atezolizumab group did have a higher incidence of more severe adverse events, and there was a higher percentage of patients in the atezolizumab group that needed to discontinue treatment. When it came to grade 5 events, the atezolizumab group did have a higher percentage of patients that experienced them, but the investigators did note that only 2 patients in the atezolizumab group did experience treatment-related grade 5 events, while in the FOLFOX group, both of the grade 5 events were unrelated to treatment. The most common adverse event of any grade experienced in both groups was fatigue, while for more severe events, both groups experienced decreased neutrophil count, which is to be expected with the FOLFOX regimens that both treatment groups received. Ultimately, the authors did conclude that adding atezolizumab to FOLFOX would significantly improve disease-free survival in patients with resected stage 3 deficient mismatch repair colon cancer compared to FOLFOX alone. And I'll say for the strengths of this study, most baseline characteristics in these groups were similar, and analyzing an intention to treat population is also representative of real life practice since patients may not all necessarily be able to receive the full course of treatment. In addition to that, when it comes to demographics of patients that participated in this study, they are mostly representative of those with colon cancer and applicable to the patient population at Monument Health. Despite this, there are limitations to this study. One limitation is that when it comes to the efficacy of atezolizumab and FOLFOX for pediatric patients and young adults with colon cancer, it is not known how effective this would be. There was only one patient in the atezolizumab group under the age of 18, but there's not any information released by the trial at the time of this recording in the supplementary appendix or trial article. This is possibly due to confidentiality reasons. But the reason this is important to consider is that there is a higher incidence of colon cancer in young adults. So it'd be important to know how useful these treatment regimens could be for a younger population. There also was an underrepresentation of patients of African and Indian descent, and there has been studies that show a higher incidence of colorectal cancer and mortality in this patient population. Ultimately, NCCN guidelines now recommend the addition of atezolizumab with FOLFOX for adjuvant treatment of patients with stage 3 deficient mismatch repair colon cancer based on the results of the ATOMIC trial. I think this makes a lot of sense because this trial did find a statistically significant difference in disease-free survival, so patients with this histology can benefit clinically from adding atezolizumab, especially since patients with deficient mismatch repair colon cancer would have a higher likelihood of mutated cancer cells. It would also be interesting to see in the future if NCCN guidelines does blanket approve more immune checkpoint inhibitors after more studies are done in this area, like they did with metastatic disease. I also do want to highlight that Monument Health did participate in this study, and this is a great milestone for our institution since this trial was published in the New England Journal of Medicine, and this is the first clinical trial that we've participated in that has been published by a reputable institution. These are the references I used for this clinical pro presentation. If you have any questions about the contents in this clinical pro presentation, feel free to reach out to me at this email address. I hope you all really enjoyed this clinical pro presentation. This is a very interesting clinical trial that Monument Health had the opportunity to participate in. I find this to be a great milestone for our institution, and I am looking forward to future clinical trials that will be published in the New England Journal of Medicine and other reputable journals. Thank you.